Hi, I'm Dr. Nasreen Alsayed, endocrinologist and lipidologist from Kingdom of Bahrain, Middle East. And today I'm going to talk about can newer diabetes drugs manage obesity, diabetes, and atherosclerosis risk all at once. These are my disclosures. So to start with, we know that diabetes is actually considered cardiovascular risk equivalent, and patients with diabetes compared to non-diabetic individuals have higher risk of cardiovascular events, whether it's coronary artery disease, cerebrovascular disease, or other vascular deaths. And despite the advances in standard of care, most patients with diabetes die from cardiovascular causes. And as a matter of fact, people with diabetes and coexisting cardiovascular disease could die 12 years earlier than those without diabetes and CVD. And the pattern of CVD and diabetes is characterized by earlier onset compared to non-diabetics, accelerated organ damage, worse outcomes, and substantial costs. So type 2 diabetes is therefore a cardiovascular risk factor that determines the need for cardioprotection as emphasized in clinical guidelines. This is what I'm going to show you later on. Now, if we look at the interrelationship between diabetes, obesity, and cardiovascular disease, this is a data derived from a UK biobank participants, more than 450,000 patients, comparing patients with and without diabetes. And as you can see, looking at the green bars, you can see that having diabetes only increases your risk of adverse cardiovascular outcome. But if you have a combination of diabetes and obesity, then the risk is higher in terms of risk of cardiovascular death and adverse cardiac outcome. So when we look at diabetes and the approach to diabetes as a chronic disease, it's very important to note the interrelationship between the cardiorenal metabolic system. So the heart is the most metabolically demanding organ, susceptible to changes in volume and metabolism. And then we have the regulation of energy, metabolism by liver, pancreas, and fat. And on the other hand, the kidneys play a key role in glucose and volume homeostasis. Therefore, when we tackle diabetes management, it's very important to consider a holistic approach by not only reducing HbA1c and controlling glycemia, but weight is another key consideration beyond glycemic control in order to manage the cardiorenal risk. It's very, of course, essential. And guidelines currently recommend medications that provide and target these multiple systems, the cardiorenal and metabolic pathways altogether, in order to prevent all the diabetes-related complications. And most emphasis are currently on these classes of agents, so the GLP-1 agonist on the incretin therapies, and these are a GLP-1 receptor agonist, GIP, GLP-1, a combination or dual agonist, and the SGLT2 inhibitors. So when we look at the GLP-1 receptor agonists or incretins, and these are peptide hormones released by the L cells and the intestine and the colon, and they exert their effect through their binding to the GLP-1 receptor at different target organs. So at the brain level, they have a neuroprotective effect and they decrease appetite. At the stomach level, they decrease gastric emptying. At the pancreas level, they increase insulin secretion and decrease glucagon secretion. And mainly on the beta cells, they increase glucose-dependent insulin secretion and increase insulin biosynthesis. And at the muscle and adipose tissue, they increase glucose uptake and storage. And at the liver, it decrease glucose production. And finally, at the heart, cardioprotection and increase cardiac function. So when we look at this class as a class in terms of efficacy on glycemia and HbA1c lowering, this slide shows you different efficacy trials looking at different GLP-1 receptor agonists in the group, such as albiglutide, dulaglutide, liraglutide, exenatide, and semaglutide. You can see that all of these studies have shown statistically significant reduction in HbA1c from baseline, some of which actually achieved even higher and more significant HbA1c reduction, reaching up to 1.8 or 2% from baseline. And if we look at their effect on the weight, you can see from all these clinical trials that there was a statistically significant reduction in the weight from baseline, and the weight reduction ranged somewhere between 8 to 9 or 10% up to 20% with the dual GLP-GIP receptor agonist. What about in terms of cardiovascular outcome? GLP-1 trials show superior cardiovascular outcomes of time to the first event of cardiovascular death, MI, and stroke. There have been multiple trials. Liraglutide, the leader trial, was the first trial among the GLP-1 receptor agonists to show MACE reduction, and this was liraglutide compared to the placebo. We have 3 trials with semaglutide. We have the Sustain and the Pioneer trial. Sustain showed superiority to the comparator, while in the Select trial that compared in patients with no diabetes, non-diabetic patients, just with obesity, it even showed superiority in terms of MACE reduction. Delaglutide similarly showed superiority in terms of MACE reduction. Tirzepatide and supra-CVOT showed non-inferiority compared to delaglutide, so it showed its cardiovascular safety and established cardiovascular benefits compared to delaglutide. And we have lixisenatide showed also non-inferiority. Now, if we look at the GIP-GLP, which is a dual agonist, such as tirzepatide, and it combines and gives you sort of more powerful glycemic reduction and weight loss because of its dual action on GLP-1 and GIP receptors, primarily affecting the beta cell and the alpha cell in the pancreas, and thereby increasing cellular glucose uptake and reducing hepatic glucose output. And when we look at the effect of the dual agonist, effect of the tirzepatide and glycemic control, it significantly reduces HbA1c in patients with diabetes, and the higher doses of tirzepatide has achieved even a better glycemic control. And when we look at the weight in tirzepatide, again, compared to the comparators and the placebo, you can see at different trials. In the SURPASS trial, it showed significant weight reduction, reaching even up to 20%. And this was seen with higher doses of tirzepatide, the higher we go. As you can see in the middle here, this is the 10 milligram dose versus placebo, and the 15 milligram versus placebo showed more profound effect on weight. What about cardiovascular outcome trial? As I showed you earlier, from the SURPASS CVOT trial, tirzepatide was non-inferior to delaglutide in its cardiovascular safety and positive cardiovascular outcome. But this was a recently published study that is a real-world evidence that was just recently published during this month in Nature Medicine. And this data was derived from a U.S. insurance claim data. And they looked at 5 cohort studies, and they tried to emulate the data and compared it with the RCTs, such as the Sustain and the SURPASS CVOT. And the surprising result, the results were amazing because it actually was parallel to the RCTs. So there was tirzepatide and semaglutide actually showed both equal cardiovascular protection in terms of all-cause mortality, myocardial infarction. Tirzepatide and delaglutide again performed very well, and actually slightly better compared to the RCTs. And again, semaglutide was superior to sitagliptin in terms of cardiovascular outcome. Going to the SGLT2 inhibitors, we can see that SGLT2 class is a fascinating class. It's a molecule that binds to the SGLT2 transporter and the proximal convoluted tubule of the kidney, where 90% absorption of the glucose happens. So it blocks that, and the net effect is the glucosuric effect of these agents, and thereby reduction in the plasma glucose levels. And if we look at the efficacy of this class, you can see there is a significant reduction compared to the placebo in HbA1c among the different agents in this class, whether it's empagliflozin, cana, or dapagliflozin. And also significant weight reduction in this class, again, parallel to the GLP-1, even though the GLP-1 produces still more profound weight reduction compared to the SGLT2, but yet they produced magnificent weight reduction. And when we look at the cardiovascular outcome trials in the SGLT2 inhibitor class, we can see the different trials such as EMPA-REG examining empagliflozin, CANVAS examining the canagliflozin, DECLARE DAPA, and the VERTIS examining ertugliflozin. You can see across the trials, all the agents show significant reduction in hospitalization for heart failure. The cardiovascular death was also reduced, but more profound for the empagliflozin. The kidney outcomes, magnificent. As you can see, the profound reduction was 47% seen with the dapagliflozin, followed by canagliflozin 40%, and then we have the empagliflozin 39%. And the all-cause mortality was even significantly more for the empagliflozin, but yet other agents were also showing a decrease in all-cause mortality. So again, real-world evidence, looking at the empagliflozin, the EMPRISE was real-world evidence compared to the EMPA-REG outcome. It was parallel. The findings actually complemented the RCT finding. Similarly, in Darwin, type 2 diabetes, looking at real-world evidence with dapagliflozin, it showed its anti-proteinuric effect in patients with type 2 diabetes. Again, we have the CVD real, again, another real-world evidence examining different SGLT2 agents, and have shown in real world their positive effect on all-cause death and hospitalization for heart failure. So when we look at the GLP-1 and SGLT2, we can see the spectrum of these two classes, their positive effect on MACE outcome, cardiovascular, hospitalization for heart failure, and kidney outcomes. Even though we can see the benefit is more seen with SGLT2 in terms of hospitalization for heart failure and kidney outcomes, and the slightly more benefit with the GLP-1 class for the MACE outcome. But in general, two classes produces really amazing and fascinating results in terms of MACE and kidney outcomes. Now, what about combining SGLT2 and GLP-1 receptor agonists? So in these two studies, it was compared having a GLP-1 as a monotherapy versus combination with SGLT2 on the left, and having on the right SGLT2 monotherapy versus combination with GLP-1. And you can see that the MACE reduction was really significant when the combination was considered. So 30% reduction on the left side and 29% reduction in MACE on the right figure, as you can see. And again, the combination was augmented in terms of glycemic control and weight reduction when we combined SGLT2 and GLP-1 receptor agonists. And this is actually, all these data is really translated in the guidelines that we are seeing now. All the updated guidelines, for example, the ADA 2025, emphasize any patients with diabetes, established cardiovascular disease, established kidney disease, or obesity. These two classes should be highly considered. Similarly, in ACE 2023 guidelines, any patient with overweight, obesity, GLP-1 receptor agonist or SGLT2 should be considered. Again, the European Society of Cardiology highly emphasized on the role and given a class 1 evidence for these agents in patients with type 2 diabetes, cardiovascular disease, and kidney disease or obesity. These agents should be highly considered. So the key take-home messages from this talk, it's very important to note that type 2 diabetes treatment is no longer glucocentric. A holistic approach to targeting the cardiorenal metabolic system should be considered when treating patients with type 2 diabetes. GLP-1 receptor agonists or the dual agonists and SGLT2 inhibitors are the pharmacotherapies for type 2 diabetes. And yes, they can give you excellent glycemic control, cardio protection, renal protection, and weight loss altogether. And with that, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Alsayed. That was a fantastic talk. Let me ask you, so when we have a patient with type 2 diabetes that we're seeing newly diagnosed, what should we be doing? Because you've shown us all these benefits of the GLP-1 class, the dual agonists, and the SGLT2 inhibitors. Now we seem to have so many options for treatment. How do we personalize this? How do we choose which, or do we always start with both? What would be your considerations?
Yeah, thank you, Roopa. That's an excellent question. And this is what we face in clinical practice on daily basis. So individualization is very important. And as we mentioned, we need to have this holistic approach. So the evaluation of the patient, looking at the glycemic control, looking at the BMI, is your patient in the overweight side, on the obese side, looking at the full cardiovascular profile, examining their lipid profile, looking at the inflammatory markers. I measure further, details, looking at their, other metabolic parameters, whether they have any evidence of fatty liver disease, whether checked by, lab investigations, imaging. That would give you really, this detailed evaluation would give you really where your patient stands, whether they are established cardiovascular risk or not, if they have any evidence of kidney involvement, urine ACR, and so on. So if you have a patient with having obesity, evidence of liver disease or fatty liver, increased inflammatory markers, all of that, why would not I choose? And there is evidence of like proteinuria, then definitely these agents should be considered, and I will consider them over the routine standard of care, because you will definitely see a benefit with that. And having said that, it's very important to note that these class of agents, they have these pleiotropic effect also, their anti-inflammatory effect, and thereby decreasing the inflammatory markers based on what you told us today.
Yeah, so I completely agree with you. I think, when I see a patient in clinic for the first time, maybe newly diagnosed, I tend to now start directly with a combination treatment quite earlier than I used to, not so much this stepwise approach we used to have. And I try and get in one of these agents in very early. So typically maybe metformin with an SGLT2 inhibitor, and then try and get in a GLP-1 receptor agonist as well, because you showed us these benefits, right? Of combining them both, we can get cardiovascular protection, right? So that would be where I would go. So let me ask you as well about about lipids as well, right? So we know that controlling the diabetes, but how do these agents affect lipids? And my third question, and I'll ask it now so you can phrase it, they both have differential effects on cardiovascular risk, right? Because they have different mechanisms. So what is your take on that as well? When do we use one more than the other? So both of these questions.
Yeah, so that's very important, because the type of dyslipidemia that we see typically in diabetes is the metabolic type of dyslipidemia. And this is a highly atherogenic dyslipidemia. So by improving the metabolic profile, lowering the insulin resistance, which is the driving factor for the metabolic dyslipidemia in these patients, you are actually reversing the atherogenicity that you see with the adverse lipid profile in these patients. And we do see really significant improvement in the lipoprotein profile that is associated with glycemic control, decreasing in insulin resistance, and also weight loss achieved with these agents. So definitely there is a great impact on the pattern of the dyslipidemia. Now, the way that the mechanism of different classes is a bit different in terms of the way that they give you the cardiovascular protection. the SGLT2 class has its, the effect on mainly on the kidneys, the glucosuric effect. So they are probably more of a class that sort of regulate the volume distribution in the body, and thereby they have some their effect on the cardiac, contractility and performance in that sense. And thereby you could see their benefits more in patients with evidence of, heart failure or early stages of heart failure that sometimes it's not even clinically detected unless you measure like certain markers such as the proBNP and so on. Similarly, their effect is even more pronounced in kidney in patients who have, proteinuria, because we have the evidence for this class more over the GLP-1 class. But again, the GLP is mainly derived through their metabolic pathway, GLP-1 receptor effect, and the weight loss pathway in improving the cardiovascular outcome.
Yeah, I mean, I see them more as the SGLT2 inhibitors having a more hemodynamic benefit, and the GLP-1 or the incretin classes, agonists, either dual agonists or GLP-1, having a direct effect more on the atherosclerosis. So that's why we see the differential benefits when you showed the studies, right? With MACE, the GLP-1 seemed to have more benefit, but with heart failure and kidney outcomes, the SGLT2. So combining them both, we're going to really holistically manage our patients, right?
Absolutely. And this is the idea, is the holistic approach now when treating diabetes. Really, I mean, even it's not wrong, according to the guidelines even, that you can start the initial therapy with these agents. You can override even over metformin if clinically indicated. If your patient fits the profile, yeah, why not? The earlier you start with these agents, the better would be the outcome.
And we know that in the future, many more of these agents will become available, again, with different agonisms. So I think, again, this is going to be a very exciting field. We can really personalize our treatment for our patients in the future.
Fascinating field. That is fascinating. We're going to have the triple agonists. We're going to have the oral agents. We're going to have the agents that maintain or prevent muscle loss with the weight loss or the fat loss that is happening. So really fascinating, amazing class of agents.
Thank you very much, Dr. Alsayed. That was a great talk, and I really enjoyed discussing with you. Thank you.
Thank you. Thank you very much. Thank you.